It's time for the Kim Hammer Show, where you'll learn how your state government affects you, your family, and community. Here's Kim Hammer.
Good afternoon. Welcome to the Kim Hammer Show. Thanks for joining us here today. I've got Ben Bowers over here. You want to send in a question for the topic of discussion today, you can go up to the Facebook, go over there to the video section and the comment section, and you can send in a question. We did get one from a viewer earlier, and I'll respond to that after a little bit. It's not on topic with the show today, but I will get to you here in just a little bit toward the end and give you an answer to that. Joining us today is to discuss the topic of suicide is Dr. Dr Corso. I'm going to let him give you his credentials so you know that he's an individual I just didn't get out of a Cracker Jack box somewhere. He comes with a rather lengthy resume, a lot of experience, and we're going to be talking about a difficult subject today, but it's really one that needs to be talked about. It's not one that we need to try to hide with a stigma or anything that would suppress, but in reality, the subject is going to be dealing with suicide. I want to thank our sponsors for helping make today's show possible. Everett GMC Buick down in Saline County, there at I-30 and Highway 5 or the Benton Parkway overpass. Go down there and see Dwight, Susie, and you can get a great Everett Buick GMC product. And they have those that, even though they're used, they still carry a great warranty on it. So encourage you to take advantage of the great deals that are being offered now, even while this COVID mess is going on. They are still giving good deals, in fact, better deals probably than what you could have got before the COVID. So take advantage of that. Go down and get your car serviced down there. They got a really good service rating as far as the way they take care of their customers, both before, during, and after the sale. Then if you're in the market for real estate, I encourage you to go down there and check out Baxley Phillips Mowdy. They're at Spring Hill and Highway 5. They take care of Saline County primarily, but they have their footprint all over central Arkansas, dealing both with residential and commercial. And also on the rental side, they do have a rental division for both commercial and residential. So you could just make them your one-stop, does-it-all realtor needs. And then always Edwards Food Store. I was in there again this morning, and the one there at Bryant, and they are, as I always tell you, they're very clean. They were well stocked. They had extra toilet paper in the shelf. Paper goods were in the shelf. They had just very few. In fact, I didn't see any holes in their shelves at all. They got some great prices. You can shop online, and they will have the order ready for you to pick up there at the curbside. And they're practicing great social distancing and other things to help keep the COVID disease beat back by wiping down the cart handles and just everything that you'd want in a good, clean store. So I encourage you to support Edwards Food Store. They're a great family-owned store that will take care of you. All right. Joining us now, Dr. Dr Corso. And Doctor, we're glad to have you on the line today. And if you will, just start off by telling the folks where you reside and a little bit about yourself personally, if you don't mind, just so they can get a little comfortable with who you are as a person.
Thank you, Senator Hammer. Glad to be here. My name is Dr. Dr Corso. I am a clinical psychologist, and I'm also a board-certified behavior analyst. I come out of the great state of Virginia, and a little bit about my background. I was trained as an active-duty Air Force psychologist several years ago, and now I am just a civilian. But that's where I got a lot of my experience and training, researching and managing suicide at the population level. And I've been fortunate enough to be able to continue this work once leaving the military. So thanks for having me on the show, sir.
Well, first of all, we appreciate your service to our country, and I know that's provided some valuable experience and insight for you as far as dealing with this topic, because suicide is not a respecter of degrees, educations, or anything else. It'll take whoever it can get. And so with your experience in the military background, thank you, first of all, for your service. But how was it that you got interested in dealing with suicide in the first place, and what was it that brought you into the field? And also speak about your experience, and you can go ahead and reference your biography. And we'll get this up on our website, which incidentally, we do have our website full blown and going now. It is, you got to put it in as thekimhammershow.com, thekimhammershow.com. and you can go up there and get a lot of valuable information that is hot off the press. A lot of it is, and we'll get this put up there. But tell them a little bit about your biography and how was it that you got interested in dealing with suicide in the first place?
Well, I got into the Air Force right after 9/11. Had some family members in the towers up in New York. I was in graduate school at the time, actually here in the Washington, D.C. area when 9/11 happened. And so once I got into the Air Force, the primary conditions that we were trained to focus on, because they were the biggest problems, of course, were post-traumatic stress disorder and suicide. For much of the wars, we had more suicides than we had deaths by enemy fire. And so it quickly became an area of focus. And the Air Force, for several years, had done an excellent job bringing in the best and brightest suicidologists from the academic field to train us and help us make sure we knew how to curb the problem. So that's what interested me in suicide. I also do a lot of work in primary care, which is kind of unique for psychologists, although it's becoming more common because we know that 45% of people who die by suicide saw their primary care provider within 30 days. And so it becomes a window of opportunity to try to reach people.
Well, I tell you what, help people understand the different disciplines. You talk about primary care physician, which would be your typical family doctor. But as far as the different disciplines that actually have an involvement in a person's life who is contemplating suicide, walk through that and what the different skill sets are for each one of those disciplines so that maybe we could understand who is maybe more proficient to deal with somebody who is thinking about suicide. And if you want to take it even into the training that they get so that when somebody presents themselves to them, what level of training they may have that would either might even come in a little bit under what they need to have, or they might, if there is such a thing, be even overqualified to deal with somebody who may present as suicidal.
That's great. That's great. So I wish we had people who were overqualified, to be honest, but the statistics aren't as rosy as I'd like. Let me back it up and try to speak to what you just asked, Senator. So within primary care, usually your most common person you'll run into is your family physician. That's someone with an MD, sometimes a DO. They've gone to medical school. In some areas, typically it's lower population density, or some special circumstances, you'll have physician's assistants or nurse practitioners, and that is fewer years of training. Typically, those folks are referred to as mid-levels, meaning that they can probably handle about 80% of the population, but the remaining 20% are too complex, and you definitely need the skill and expertise of a physician.
Go ahead.
Oh, go ahead. No, go ahead, sir.
So somebody presents that may be contemplating suicide. How are they currently treated under the existing protocol that's used to handle somebody that's presenting as suicidal?
So the U.S. Preventative Services Task Force says that there's not enough research to either support routine screening for suicide in primary care, or to say that it's not beneficial. So right now, at that level, we don't have any research that definitively says screen everybody at every appointment, or don't screen anybody unless they say they're maybe depressed or anxious or have chronic pain, some other condition that may be closely tied to suicide. And so you have variable practices, different organizations, different hospital systems do different things. Now, of course, my training was in the Air Force, where you had a lot more people who had access to firearms. And believe me, they knew how to use them, typically. So that was one reason to do routine screening. And then the other reason is that if we know 45% of people who die by suicide saw their primary care clinic within 30 days, why wouldn't you try to ask and sort of head it off before it gets worse? Here's what the real kicker is about it, Senator Hammer, is that those 45% of people who came into their primary care clinic, only 40% of them were there for a mental health issue. The other 60% were there for some other issue. things like GI problems, stomach problems or discomfort, or cardiac problems or hypertension. So if we don't ask those other 60% because they're not here to talk about a mental health condition, we're missing 60% of the people who we could try to help by routinely asking about suicide.
But if they come in for something and suicide is not on their mind, and we ask them, and I think I remember last time I went to my doctor, there's kind of like a standard 5-question, and I can't remember what they are, but they're like 4 or 5 questions. And when they're asking you those questions, they're wanting to know, are you even thinking about it when you came in? By the fact that we're
Right.
even bringing it up to the population that comes in to see their PCPs, and maybe I didn't walk in that office with that on my mind, are we harming them by even bringing it up through even the simplest of questions? Or kind of help me get a handle on that, how it is that we're not, introducing them to think about something that they weren't thinking about before they came in the doctor's office?
That's a great question. So there is some sort of a myth or some belief out there that if we ask someone if they're thinking of killing themselves or ending their lives, that we're going to, by the power of suggestion, give them an idea that they hadn't thought about before. And there's just no evidence that supports that. What the evidence does support is that when people are suicidal and they have a stomach ache, they'll still come in to get their stomach ache taken care of, because suicide is such a monumental decision that whereas a stomach ache is something that when I wake up in the morning, if I have a stomach ache or a headache, that's something that impacts me right now, this second. So I'm more likely to go in and see my doc, even if I am suicidal. So to answer your question, there's no harm in asking. And there are lots of public health campaigns that try to educate the public. The idea of gatekeepers, if you have a family member, a friend, and they're struggling, there's nothing wrong with you coming right out and asking, hey, have you been having thoughts of ending your life? Have you been having thoughts of killing yourself? And we're not going to drive anybody to kill themselves just by asking.
But a lot of people are afraid to ask, because if the question comes back and they answer yes, now these people are now they've got the responsibility of knowing that this person is threatening to harm themselves, and they don't know which direction to turn with that. Traditionally, and you correct me if I'm wrong, traditionally it's a call to 911 that you've got somebody in the home that's threatening suicide, or it's inpatient treatment at a psychiatric hospital. Or what other avenues am I missing? Or am I totally off point when I say that if you were to ask somebody what's bothering you, and you were to say, well, are you thinking thoughts of suicide? The reason that question doesn't get asked is because they're afraid the answer to the question is going to be yes, and they won't know what to do, or they're afraid of the stigma that's going to come with it.
That's exactly right. So a lot of people won't ask because they won't know what to do if the person says yes. And the best guidance that I can share is to just be a good human, be a good person, be a good citizen, a good neighbor, whatever the relationship there is, and get the person to someone who has a higher level of training. So that could be the suicide hotline, which is 1-800-273-TALK, TALK, or it could be bringing them to the ER, the emergency department, emergency room, or it could be getting them in to see their primary care provider. These days we have different models for primary care, things like the medical home model, where we have certain amount of appointments we reserve for sort of walk-ins and acute problems same day.
I'm reading off your deck sheet, which I think you gave us permission, or let me confirm you're giving us permission to put that up on my website so people can look
Sure.
at it. Okay.
Absolutely.
So Ben's sitting over here working with Elizabeth to get this up on our website, and that's thekimhammershow.com. And it's a deck sheet from a presentation that you give. One of the sheets says our poor ability to predict future suicide. And it goes on, and you were quoted as saying, according to 2 recent studies, considering the last 50 years of research, our ability to predict future suicides and suicidal behaviors is generally poor. Talk about that statement, and why is it that we are generally poor in being able to predict future suicides?
Great question. So what those studies showed, and they were published in 2017 and 2019, and what they showed is that when we look across the population, whether it's the United States, whether it's the world, whether it's just the state of Arkansas, when we look at those high levels and try to understand what are the factors that drive people to attempt suicide and what are the factors that prevent people from attempting suicide, the thing that we can't predict is human decision making. So we know that white males ages 18 to 35 who own a firearm are more likely. But guess what, sir? We've known that for 50 years, and it hasn't helped us better prevent suicide. So it's not that we can just sort of profile people based on their risk factors, because risk factors are numbers. But human decisions and judgments, that's where everything changes. So what the research is pointing to is the fact that we know certain people are at higher risk, but we can't tell who's actually going to act on those thoughts. And that comes down to human decision making. And there's a whole area of the research that talks about this. People, and if I could just explain suicide as a sort of a construct, as what it is, it's not a cry for help. It's not weakness. It's not necessarily mental illness. It's not a disease. Suicide is when you get backed into a corner and things are really tough in life and you don't know how to tackle it. And so we say that suicide is a state of ambivalence. It's a state of feeling two ways, having mixed feelings about something. On one hand, maybe you have a lot of things to live for, but you're not able to enjoy them because of all the other difficulties going on. So you have reasons for living and reasons for dying. And so when people think about suicide, it's really a part of their problem-solving gear or mode. It's their drive to try to overcome something. And they think, well, if I can just escape it all by ending my life, that would certainly stop my pain. But of course, it also ends their opportunity to enjoy all the good things that they would typically enjoy if they weren't suffering. And so when we talk about suicide and preventing suicide, we've got to get deep into people's value systems. We've got to get deep into their decision making and into that idea of what do I do when I have mixed feelings about something. And that's not something that we have figured out so far how to study at that population level. And that's why we can't predict it.
So let me ask you, and I'm going to get a little bit ahead, and I'm looking at the slide that shows the suicide rate is increasing in the United States, and you compare it against accidents, all cases, heart disease, diabetes. But I mean, according to the chart that I'm looking at on your deck slide, the suicide is actually at the highest bar. So is suicide in America, and if you have personal knowledge about Arkansas that you feel you can speak on, defend, is the suicide rate on the increase in the U.S., and what is attributing to the suicide rate being on the increase in the U.S.? And if you want to drop that down to Arkansas and make it personal, feel free.
Sure, I'll do both, Senator Hammer. So first of all, you're right on spot on there. Over the last 50 to 60, even 70 years, it's been on an incline. Now, that doesn't mean it's every year is worse than the one before. Sometimes some years are better, and then the next year is worse. So there's sort of what we call a sawtooth pattern, right? A little bit of up and down, but overall, it's increasing over time. And so there's never been a time in American history where we have suppressed the suicide rate and kept it low, meaning we haven't really cracked this nut yet. Now, again, there are some years that are better than others. For example, Arkansas in the past year actually had a better year than it did in 2000. So the 2018 data for Arkansas are actually better than the 2017 data. But that's just 1 year. From 1 year to another, we can't sort of sit on our laurels. Historically, the worst states for suicide are Wyoming, Montana, Alaska, and Idaho. Some of the best states, meaning the lowest suicide rates, are Hawaii, New Jersey, Virginia's among the lowest. And so all sorts of things drive what happens at the state level. Overall, no one's cracked the nut, but in certain states, we're making more progress than in others. In certain states, suicide is worse than in others. And everything from the culture and value system within that state helps to drive that. but then also the accessibility to healthcare and a mental health provider or psychiatric services can drive those statistics. Before you asked about training and deficits in training, the entire medical community relies on the mental health community to help with suicidal patients. If you're a primary care provider, if you're a orthopedist, a dermatologist, a cardiologist, endocrinologist, you name it, all of these specialists, if their patient happens to say something about having suicidal thoughts, they try to get them to the mental health providers. Now, that could include a psychologist, a social worker, a mental health counselor, a pastoral counselor. It could include a psychiatrist. And all of those people in the mental health field, we assume, are well equipped to take care of these patients. But there's a problem. Only 50%, actually slightly less than 50%, of people trained in the mental health field receive formal suicide training in grad school. And the average amount of training is about 2 hours. So there's a real deficit there with our clinical training in our field. And that's one of the barriers to really tackling the suicide problem, is improving the clinical skills of the providers who are responsible for helping the population.
So typically,
go ahead.
Let's just role play what you just said. So I've got suicide tendencies. I go in to my doctor, see my doctor. I might express to my doctor that I have it, or he does the little 4 or 5 question test that is an indicator that causes concern to rise up above the radar level to where he says, hey, are you having some suicidal thoughts? And I say, yes. At that point in the primary care world, what are their options at that moment that are going to really benefit me or get me where I need to go? Because if they don't have, if they are very little trained to deal with that, I don't need to stay there. Then one of two things need to happen: either they need to get trained up to where I can spend more time with them, which we know that's difficult in the PCP world as it is now, or I've got to be referred. I got to be referred out. Am I right, wrong, or get me straight?
You're correct. You're correct. So we can't put more on the PCP's plate. Your primary care provider has got hundreds of conditions and diseases she or he is worried about. They have a ton of administrative requirements now with documentation and accountability. So it can't go on their plate. But luckily, we do have this medical home model that is a very team-oriented way of operating so that they can rely on their team members. Now, over the last 15 years, there's been this wave of moving mental health providers into the primary care clinic to help with this sort of circumstance, to help with all sorts of things like identifying depression earlier, identifying anxiety earlier, helping with sleep problems, chronic pain, any ways that behaviors or thoughts can improve our health or mental health. That's where we benefit. So this is called integrated behavioral health, and Arkansas is starting to do some of this. I was first trained on this in the Air Force. They were onto this back at 2000, to be honest. And they've spread it all across the Air Force now, the entire military system. As long as there's a clinic that has at least 3,000 patients enrolled to primary care, they get one of these integrated behavioral health providers. So these folks are especially trained to be better at managing suicide risk, because we can't have a knee-jerk reaction of just the doc saying, hey, Dr. Corso, I've got a patient here who's suicidal. And I say, okay, great. Let me send him to the ER or let me send him straight to the hospital. We've got to do more upstream. And so as this integrated behavioral health movement starts to expand, and you have IIBHN, right, which is the Arkansas Integrated Behavioral Health Network. That's a nonprofit organization that's being stood up to help continue to spread behavioral health into primary care for all sorts of problems, but of course, including suicide.
Okay, so let me stop you there because I got to take a break at the bottom of the hour. When we come back, we're going to pick up with that. And you are listening to Dr. Corso. If you've been listening at all during this program, you know that he's an individual who knows his stuff, and the subject matter is suicide. So we're going to have him held over to the second half of the show. So if you have somebody that is maybe dealing with this, it'd be a good time to get them tuned into the Kim Hammer Show. Want to thank my sponsors, Everett Buick GMC down in Saline County, Baxley Phillips Mouty down in Saline County, and also Edwards Food Store throughout Central Arkansas, over in East Arkansas. We've got to take a break, recognize some other sponsors of this station. Come back, and we'll resume the conversation with Dr. Corso here on the Kim Hammer Show.
Maybe you can relate to this. A lot of people think they're stuck with their health plan. It costs too much, or for whatever reason, they just don't like it. The great news, you are not stuck with it. There is a choice. It's called MediShare, and you could save so much. The typical savings for a family is $500 a month. Major difference maker. This is the affordable alternative to health insurance. And just to give you a little more info about MediShare, it's a Christian healthcare sharing ministry. It's worked beautifully for 26 years, has more than 400,000 members, and they've shared over $3 billion of each other's medical bills. So yes, they can help share your needs too. So you're not stuck. There's an excellent alternative. Whether you're single or married, you got a family, MediShare is super flexible. You can choose an option that works for you and start saving lots of money. You can join anytime. They're great to talk to, no pressure. Call 855-BIBLE-11. That's 855-BIBLE-11. 855-BIBLE-11.
Take The Answer with you anywhere with our free mobile app. 1011fmtheanswer.com, Amazon Alexa, iHeart, or radio.com. Breaking news and stimulating talk. 101.1 FM. The Answer.
Salem Media Little Rock just keeps getting better. If you're looking for some soul-lifting inspiration, check out 103.3 and 105.5 Rejoice, Little Rock's gospel experience. If Bible teaching is what you want, we've got you covered at Faith Talk 99.5. 93.3 The Fish is your home for real life, real hope. And our 101.1 The Answer is now the home of Rush Limbaugh. We're Salem Media Little Rock, the best in radio.
On the next Mike Gallagher Show, Georgia has moved forward with reopening some businesses in the state despite President Trump's protestations. We're expecting more protests against these stay-at-home orders as people feel their jobs, of course, are essential and people are in desperate straits. Will the president's concerns mean that we're going to be hunkered down for another month? Join us for that and more on the next Mike Gallagher Show.
Hey, welcome back to the Kim Hammer Show. I want to thank my sponsors that help make this show possible, and I want to make that disclaimer that the views and comments expressed on the show on behalf of the hosts are mine and mine alone, and I take full ownership for them. But I want to thank Everett Buick GMC down in Saline County there at I-30 and Alcoa Road. Great time to go purchase a new Buick GMC, either new or from their quality used line that still carry warranties. They'll give you great service both before, during, and after the purchase, and they do a great job in their service shop as well. And so I'd encourage you just to consider going down and supporting them. Also, Baxley Phillips Mouty Realtors take care of your real estate needs here in Central Arkansas, including residential, commercial, and they have a rental line that will take care of you on the commercial and residential side as well. If you got property that you want to list, they are experts both in residential, but they also have some key commercial sites too, do a great job of moving commercial property. So if you're in the market for commercial property or have some to sell, give them a call down there. They'll be glad to take care of you. And then Edwards Food Giant, Edwards Food Store. They are here in Central Arkansas, Edwards Cash Savers. You'll find them here in Central Arkansas, all throughout Little Rock, up I-670 corridor, on up there to BB, and then over there in East Arkansas, going Forest City and north and south to Harrisburg or Marianna, either one. You'll find great, friendly stores with good competitive prices, so I encourage you to support them. All right, back on the line, we have Dr. Corso joining us from Virginia, and we appreciate you taking time out today to be on the Kim Hammer Show. Here's, I was looking on your deck sheet, which you can go up to our website. If it's not there, they're in the process of getting it loaded up there. It's thekimhammershow.com is where you'll find our website loaded up with all sorts of good information. If you want to advertise too, there's a spot on there that you can send me a message, and we'll talk to you about getting advertised on the Kim Hammer Show. But I'm looking at one of your deck sheets, and it basically it says factors associated with an increased risk for suicide, and it gives a breakout. It looks like there's probably anywhere between 50 and 75 different triggers, if you would, that get someone to thinking suicide. But here's my question. Can a person be thinking about death, but just not necessarily suicidal? And when is it that it goes from just thinking about death to becoming suicidal?
That's a great question, Senator Hammer. So there is most certainly a difference. Just a disclaimer, if any folks have been able to find that slide deck online, it was written for sort of the clinical community, so there is some jargon in there, so forgive us for that. But this is the kind of training that we'll talk about in a minute. So there's something called death ideation or death thoughts, and then there's thoughts of suicide. So it's very common for us to hear someone say, man, I wish I weren't alive, or I wish this would just go away. I wish I could fall asleep and not wake up. I wish I could just put my head in the sand and have it all go away. That's death, thoughts of death. That's actually pretty common, and that does not consistently result in people trying to harm themselves. But when those thoughts of death involve, and maybe I'll play a role in triggering my death or making my death happen or bringing about my death, that's suicidal ideation. That's not as common, but again, it's not uncommon. So we have to be careful here. And one of the successful prongs here to an improved suicide prevention approach is educating Arkansans, educating just everyday citizens about the difference between the two. There are a few circumstances, few situations where people just lose a hold on reality and go crazy. That certainly is not suicide. It's something else, and it does exist, having some sort of schizophrenia or psychotic break. But there's not, some people, when they have thoughts of death, they get scared. And we should be reassuring people that all that means is you've reached your limit. And it's important to recognize your limits so you know when to get help, when to reach out to a loved one for support. So to your point, Senator Hammer, yeah, there's a huge difference between death ideation and suicide ideation, or death thoughts and suicidal thoughts.
I work in hospice, and so I deal with people that, are facing death all the time. And sometimes death is welcomed by those that have the terminal illness, and, they've kind of processed that the end of life has come and they're accepting to that. Their view of death is different than the view of a person who looks at suicide as their avenue toward death. When it comes to equipping a person, because you referenced this a few minutes ago in our conversation, when it comes to equipping people for death or to battle suicidal thoughts, what are some of the differences between the natural course of life, which ultimately is going to lead us to physical death? Sidebar, if you know Jesus Christ as your Savior, you only taste the physical death once, but preparing for the physical death because you got some warning signals coming versus the suicidal thought. What are some things that make them different, and how would you train differently, being that death is going to be the ultimate result for both?
So preparing for the natural process of death is a process of finding closure, of coming to terms with everything, including what's on this earth, to everything about what happens in the afterlife. If you're a person of spirituality and faith, that involves much about Jesus Christ and heaven and God and whatever your particular faith teaches you. But that's a sort of a closure. How do we make sense of it? How do we make sure that we leave in a way that's graceful, peaceful, without too much pain, where you can have your loved ones around you? That's very different from suicide, which is, how can I escape? How can I get away from all of this? How can I avoid all of this physical pain or emotional pain or trouble in life, whatever the challenge is? And so one is about finding sort of closure and being at peace, and the other is, how can I stop the pain and just kind of run away from it? And so you asked before, Senator Hammer, what makes someone actually take their lives? And so there's this point with people who are thinking of suicide where they get very emotionally activated. So either they get very irritable and sort of agitated, and at the same time, maybe they decide to cope by drinking alcohol or overusing some prescription medications. We certainly have heard of the opioid crisis. There's an overlap there with suicides using the prescribed opioid medication people have. But in that moment where they are very agitated, they've got one thing on their mind, and that is, how do I get rid of these horrible feelings I feel? I cannot keep feeling the way I'm feeling. And in those moments, judgment goes out the window. They're not thinking of anything except, let me stop this horrible feeling and this horrible distress that I've got going on right now. And so if we can slow that down, and we can, first of all, train medical providers, certainly bolster the training for the mental health community, but also train maybe advanced practice nurses, PAs, certainly physicians. If we have integrated behavioral health, we'll take it on for them. But if we can train people to recognize when patients are in that state, and even train our Kansans to recognize when their loved ones are in that state, it helps us know when to buy time, because what we know from the research is that if we buy time and get them to just sit with the distress, eventually they calm down. It doesn't take days. It takes an hour. But what we also know is people who take very lethal ways of trying to kill themselves, like let's say with a firearm, that 24% made the decision within 5 minutes, meaning they felt really upset, suicide came to mind, and within 5 minutes, they picked up their firearm and tried to kill themselves. So one of the best predictors of suicide is what people have access to, what they're able to do quickly when they're in that really agitated state. So buy-in time is really the part of the solution to answer your question.
Okay. I got about 3 hours worth of questions and about 20 minutes to get them all in. So grab your bootstraps. Here we go.
Let's do it.
So let me just kind of take what you said. I'm looking at your slide deck. Let me make a statement. You tell me if I'm right or wrong. If we see that the numbers are steadily going up in the United States, and even though we as Arkansans have flattened the curve a little bit, if the model holds true, it's going to increase its way back up. Is that a implication that the way that we're handling it now is not necessarily the best method and we need to tweak it? Or what do we need to do to get it flat and hold it flat at minimum, but turn it back down? Or is it just that more people, we're living in a society of people that just don't have the coping skills, they don't have what they need internally, whether that's physically or job security or whatever else it may be that would trigger them to start thinking about suicide? Life is just that much more complicated and we can't stay ahead of it? Or is it a little bit of both?
It's everything you just said, except for the last part. Life is not just too complicated, and it's not that we're never going to get ahead of it. Some people just need better coping skills. There's three solutions here as far as I can see, and you're right on that we are doing a great job, but there's certainly more that we can do if we want to flatten the curve or turn it downward, and that is better education for the public. So teaching people about this sort of suicide mode, teaching our Kansans what it's all about. We do a lot of good work in, if you see someone struggling, help them and get them to safety. But what we don't do well, and we're seeing positive strides in projects we've done in the Air National Guard and in the state of Idaho, is helping people just understand what suicide is so that they can help themselves. Not everybody wants to go reach out for help, but many of us are fine using tools or other ways to help ourselves. So that's the first thing, is really educating our Kansans about, if you won't go seek help, how can you help yourself? And that comes down to coping skills, right? And other sorts of strategies, may even be faith-based. Then the second prong is we've got to get better training to our medical community, because the solution is not just putting everybody in the hospital. That it's not sustainable from a financial perspective. And to be honest, there are not a lot of research studies showing that psychiatric hospitalization specifically reduces suicidal thoughts. What it does is it keeps people safe. It prevents them from killing themselves, because we've got them on a complete sort of eye-to-eye supervision, 24/7 watch. So there's educating our Kansans and the public, and then educating the clinicians. And then the third thing is we've got to do something different around how we measure it. it is a real statistical bear. It's not easy to measure. And only when we pull in multiple community stakeholders at the legislative side, the nonprofit side, certainly the hospital systems, the payers, insurance companies, we've got to get everybody together in one integrated network to be able to figure out how to watch these data so that as we make changes and roll out training or roll out community education to Arkansans, how does that affect the numbers? And if they change in one direction or not, we do something different or we do more of the same. But we have to have a proactive community collaborative approach.
What about the stigma? I mean, do you feel that we're making grounds as far as when somebody utters those words that I'm thinking about suicide, or let's just say that they've actually attempted it and survived it, and they've got to acclimate back into their family environment, back into their work environment, or go back to school with that on them? Do you feel that there's ground being made as far as like we're trying to do with the opioid addiction, and that is break down the stigma, break down the barriers? Where do you think we are in that part of the battle?
With stigma, we're making progress. A few things that are going to help us make even more progress is putting more of the suicide prevention work in primary care, with integrating primary care. When you go in to see your doctor, if you get used to them asking you questions about, do you drink alcohol? Have you had any anxiety? Have you been feeling depressed? Do you feel safe at home? The kinds of standard, you mentioned 5 or 6 questions you were asked, those standard questions, as people get used to them, it just becomes a part of your overall medical care. So that helps destigmatize things. Another thing that helps destigmatize it is just helping people talk about it more and understand it. But something we don't do as well, you mentioned if someone has an attempt and thankfully lives through it and goes back to school or work, there's stigma attached to it. Well, there's something called postvention, as you know, and postvention is what happens after an attempt and whether the person really died or whether they survived. How do you educate the community about it? How do you help the community heal? How do you help the family heal, the school, the company, or what have you? And so it's not just about what we do beforehand, but how we frame and talk about and move forward from attempts and actual suicides in our community. So we could be doing more postvention as well.
All right. So for the common layperson, give them a free education out there. Somebody brings up a conversation, just says, all this COVID stuff going on, I don't have a job. It's, just really high stress and everything. And I just wish all of this would end. And let's say that's kind of an open-ended statement that they throw out there. For a common layperson that might be engaged in a conversation with that person, walk them through what they should do to determine whether or not that's a statement of, hey, I want to commit suicide and get away from it and use that exit strategy, or it's just a cliche statement that's being thrown out there, and how you differentiate between the two. What would that conversation look like?
Great idea. Say the statement one more time so I can respond to it.
All right. So I'm going to use all the pressure of COVID-19. We're up over 130,000 people on unemployment. We got those that are self-employed that are still waiting for part of the CARES package to be initiated, and they're pretty well spending down their resources that they've got. The messaging on the boards is, hey, stay positive. We're going to overcome this, which I do believe we're going to overcome it. I think we're going to be stronger when it's all said and done. But, one of the buzzes that's kind of going on out there is for somebody that is already borderline suicidal and you heap all of this on them, and you're just having a casual conversation with your neighbor over the fence, and your neighbor says, man, this is just more than what I can handle, and I don't think I can take it anymore. I just wish life was over. And that's all they say. How would you differentiate as a layperson if it's got to be pushed down more to the backyard neighbor environment? What tools can you give them to help them differentiate whether that's a suicidal statement or that's just a I'm fed up with life statement?
Great exercise. So that sounds like I'm just fed up with life, but we do have to ask one step further. So yeah, it would be easier if life weren't over. Are you thinking of doing something about that? Are you thinking of making that happen? That's got to be the question to determine if they're really feeling suicidal or if they're just thinking about death. So that could sound like, yeah, I know what you mean. Just empathy, just being a good person and reflecting on any of what the neighbor says that you can relate to. Yeah, I know what you mean. I've got the same issues with my business or with my job or my income. And there are days where I feel that way too. But are you thinking of doing something about it? So that's one casual way to do it. One other way to do it is we know that we can reduce suicide attempts by 76% if we get people talking about their reasons for living. So another way to do it over the fence with your neighbor is, man, if all this stuff wasn't going on, what would you be doing every day? I know what I would be doing. And then you start talking about your own reasons for living and get the other person talking about their reasons for living. Because again, if they are suicidal, suicide is where we have reasons for living and reasons for dying. And the more we get people focused on their reasons for living, the more oomph, the more motivation, the more resolve and determination they have to keep trying and keep fighting the fight to enjoy those reasons for living.
Redirect them.
Yep, redirect them.
Redirect. All right, so let me ask you, you got a statement on one of your slide decks here. It says, don't try to talk a person out of killing himself or herself. What's that about?
That's for clinicians. If the best you can do for your neighbor is talk him out of it until you can get him or her to the emergency room or to get them to call 911, then talk him out of it. But as a clinician, you don't want to talk people out of killing themselves because suicide's a state of powerlessness. And if I, as a medical provider, try to talk you out of it, I'm just furthering that sense of powerlessness. I'm just sort of strong-arming you. And that's not a sustainable way about it either. There are some people who think about suicide for years and years and years and never actually try. And if I kind of push you away by trying to, or if I sort of strong-arm you and that's the way I try to keep you safe, what happens when I no longer work at that clinic? What happens if you move to a different part of the state and now I'm not your doctor anymore? So we're better off teaching people how to fish versus just giving them a fish. And we really don't want to overpower them. We want to empower them.
Okay. So with the time we got left, if for where the current once again, define the current model now is if a person suggests that they are thinking suicidal thoughts, we have been trained, you need to get them in the hands of a professional. That might mean dial 911 so law enforcement can come take them into their hands and get them, to a ER, or you get them to an ER, you get them to the PCP, you pass it off. In other words, you get them in a secure environment.
Right.
And then they get the treatment that they need. And depending on what your view of psych hospitals are and other institutions, whether they're just keeping them safe or whether they're actually equipping them with some real tools that once they leave, they have the ability to, overcome those thoughts or battle over those thoughts. What are you proposing would be good improvements to the current system that, if applied, would help flatten the rate and hopefully start to turn the rate down long-term sustainable?
The recommendation is keep doing what we're doing with trying to get people to that next level of care. Don't change that. But when I talk to mental health providers across the country, I even do some work abroad in other countries, just the basic difference between death thoughts and suicidal thoughts, at least half the mental health providers and physicians and nurses I've trained, they don't realize there's a difference. And so they're hospitalizing people just based on thoughts of death, not thoughts of suicide. That's really wasteful. And that also runs patients through the ringer and through this whole process that they don't need to go through. So we've got to train our medical community better. And then we've just got to train every citizen better. We've got to get them to be able to be empowered, to have confidence that if I bump into this thing called a suicidal thought, number one, there are resources out there that are helpful and I know what they are. And also, it doesn't mean I'm going crazy. It just means I'm in a tough spot, but I've got to focus on my reasons for living so I can get through it. And I've got to know what resources are out there to support me through that process.
All right. Am I being detrimental or am I being beneficial to make this statement? Just because a person may have a suicidal thought doesn't mean that they want to commit suicide, and they need to be equipped with the tools to be able to differentiate the two so that if they recognize that maybe that is a precursor to an actual attempt to commit suicide, that they would want to seek out the professional help that they need to get versus realizing, no, this is just a passing thought. It's part of the reality of life. It's a death thought, but it's not a suicide thought. Is that a good mindset for people to have, or is that detrimental?
Correct. No, that's a good mindset. And it all comes down to confidence. I mean, if you're confident that you can tackle it yourself, well, we better give people tools. Just because someone's in pain doesn't mean they want help, right? I mean, we have plenty of people who acknowledge having a problem, whatever the problem is, or acknowledge having a challenge or something they're struggling with, but they'd rather handle it themselves. Well, if we're not going to change who they are, right? As in terms of their preference for seeking help or not seeking help, but we can at least equip them with ways to handle themselves and to know their limits. So I would agree with the statement you just made.
Okay, so in about 2 to 3 minutes we got left, what is the best way? Now you've worked with Idaho, correct? Am I right on that? You've worked with Idaho, and where all of you work?
For the last 3 years, we've been doing a lot of work in Idaho.
Okay. So in areas where you work and what you're proposing, you've put into application, how do you go about getting this basic information down to the lay people level? Do you do it through the PCPs, just continually asking these questions and be educated at the PPC level? Do you do it through the public schools? Do you do it through higher ed? Where is it that you layer it in so that this thought process begins to take root?
It's all of the above. We've got to get into GME, graduate medical education, in the medical schools, nursing schools, graduate schools, putting some requirements in place to increase the standards. So that's one step. We haven't gotten that far yet in Idaho. We're not there yet, but that's probably the most important step because that's way upstream, right? Then the other step is to get integrated behavioral health providers in the clinics to be able to work with the PCPs so that we're not waiting till people go to the ER with a suicide attempt already underway or just about to attempt suicide. We've got to catch it earlier. And then we've got to get that grassroots community engagement, which only happens with these integrated behavioral health networks like we've had in Idaho for the last 3 years, to pull all the stakeholders together and figure out how to draw on our multiple resources and rally around decreasing the suicide rates.
1 minute or less, put a spiritual perspective on all of this.
What's the most important thing to you in life, Senator Hammer? Whatever that is, that's your reason to live. And for many of us, it's spiritual, and our value system is after God. And so if that's the most important thing to me in life, that's got to be my compass, right?
Well, I believe that at the end of physical life, we have to stand before the Lord, and those that have a personal relationship with Christ will experience eternal life. Those that do not will experience the second death, which is an eternal separation from God. You know, my motivation is that I want to stand before God and know that the life that he gave me to use here on earth was invested as wisely as possible. And that's what motivates me to keep on going day after day, even though life sometimes is hard. I know at the end of the journey, when he calls me home, I want to hear him say, "Well done, thou good and faithful servant." So we all need a motive to keep pushing through. We've had
Absolutely.
Dr. Corso with us and calling in from Virginia. Appreciate it very much. His information is going to be up on the website. That's the KimHammerShow.com. You can go up there. He gave the, if you are struggling with thoughts of suicide, you want somebody to talk to, the number is 800-273-TALK. 800-273-TALK. We'll get Dr. Corso back on again and just have a little bit deeper dive on it. Let me just again say thank you to my sponsors, which would be Everett Buick GMC down Saline County there at I-30 and Highway 5 overpass, or the Elko overpass. Also want to say thank you to Baxley Phillips Mowdy Real Estate there in Saline County in Central Arkansas, and Edwards Food Stores. We appreciate them. Again, the views and the comments of the host are mine and mine alone, and we appreciate you listening to the Kim Hammer Show and hope to have you back with some friends next Saturday here at noon.
101.1 FM. The Answer. KDXE FM. Kamak Village, Little Rock. A Salem Media Group station. 101.1 FM. The Answer.